My name is Lilian Chiwera. I am the interim chair for the newly formed surgical site infection prevention group. So I take it you all specializing in decontamination, sterilization, is that right? Yes? Where do you guys work? Theaters? Infection control? Oh, awesome. So I am going to be talking about surgical site infection prevention today. So preventing wound infections after surgery. And I'm sure you all agree with me that in as much as we can do, what we can do to make sure our equipment is clean, for those patients when they have their operations, so the decontamination and sterilization, there is a lot more work that we need to do along the patient's pathway, to ensure that that patient is actually got safe surgery and doesn't incur any harm. So I am presenting on this new global group, which was formed within the last year. So a bit of disclosures for me. I'm the chair. They made me the chair. I don't know what I'm doing, to be honest, at the moment, because, we're all still learning. But, I worked at Guy's and St. Thomas's for many years. So initially, when I qualified, I worked in recovery, and then I did cardiac ITU, general ITU. And then in 2009, I moved to infection control, where I helped to set up the surgical site infection surveillance and prevention service at Guy's and St. Thomas's. COVID hit, I volunteered to go to ITU. My brain died a little, so I decided to take a bit of a break, and I did digital transformation at Darren Valley for about 10 months, and then last year I was infection control matron at Sherwood Forest. So that's my experiences. But before that, before I became a nurse, I used to work as a microbiologist for pharmaceutical companies. So, kind of consolidating all that experience now into the SSI prevention work. Okay, so first things first, do the sick no harm. It's simple, isn't it? And again, when we talk about do the sick no harm, and what I keep saying to everyone is all of us, if you think about in the UK, I think 1 in 4 of us has got some kind of mental health problems, right? So in as much as you wanting to not do your patients harm, you also don't want to do harm to your colleagues. Is that right? So you want to treat each other well, okay? So creating, a safe working environment is equally as important as making sure that our patients are well looked after, okay? So if you are having a rough day or someone hasn't treated you well, perhaps you may not look after your patients as well as you should be doing. So for me, psychological safety is very important. So we want to be treating, staff safety and patient safety, equally, okay? Very important. So for the next slide, and I've kind of said, reuse psychological safety for a sustainable future, okay? So reuse is our acronym, as the SSI prevention group, okay? So what we want to be able to do is for any infections, really, we want to be able to reduce the burden, isn't it? We want to reduce the burden of avoidable harm for our patients, okay? But, how do you know where you are if you're not measuring? So we want to have methods of measuring accurately so we know where we are, and then we can target our interventions effectively. When you've got your data, okay, you want to be able to use that effectively. Have meetings, look at what you could have done better so that, patients don't incur harm in future. Like I said, I think when you're looking at your how can we prevent wound infections after surgery? You're also looking at how can we look after our staff in the operating rooms, in the sterilization department or decontamination, or anywhere along the patient's journey. Okay, so what we are going to be working on as the new group is actually a family dynamic model. What you can see there is what we've tried to kind of, think about, what it's like to be in a happy family. We know that, sometimes, the family dynamics can be complex. But if you are in a happy family, you all support each other, when someone is smarter than you, you encourage them. You are proud of them. Is that right? And if someone makes a mistake, mom will say, make it right with your brother, okay? In a nice way. You all super supportive. And like I said, I think, we know that, in workplaces, things don't always, go well. And we want to be able to address, the staff safety side as well as the patient safety. So if you see from this reference, actually from the BMJ, incivility is a common issue within healthcare in the UK. So experienced by at least 1/3 of staff. So how many have experienced incivility in their workplace? Was that handled okay? Did you feel that that was handled okay? Yeah? How did that affect your work? So these things happen, but we want to be able to have those, psychologically safe workplaces where you are able to say, hey, I don't like what you're doing to me, and someone doesn't feel offended, and then you correct whatever needs to be corrected. Like I said, I think, these are things that we need to be thinking of alongside, the patient safety stuff, okay? You can't treat these things separately. If I'm not well, maybe my patient isn't going to be well as well. Okay, so what was your last CQC or regulatory inspection result? Do you know for your hospitals? Do you know what it was? It was good for yours? How was it for everybody else? Good? Outstanding. Oh, amazing. We love that. Tell us more about it. Okay, so as part of, the new group, what we're going to be doing when we go to organizations is actually see where they are in their journey, and we want to be able to support them, so that we can get to outstanding. And like I said, I think especially in larger organizations, sometimes you do see people running about when CQC is about to come. Are we doing things for CQC? Why do we run around when CQC is about to come? Do we have to put our house in order when the visitors are coming? Maybe we do, but is it really the right thing to do? No. So we want to make sure that, every single time, our patients are getting the best care. So even if CQC were to come, right now, you don't panic, okay? You don't have to change how you normally do things for CQC. This is for patients. Imagine that's your mom, brother, sister, on that bed. So we really don't want to, but it's also good for you to know exactly where you are, around these things, and then, work with your organization to make sure that, you are delivering the best. Okay, so I've kind of, started by talking broadly here, so I'm going to narrow it down now to surgical site infections, okay? We know that wound infections after surgery, they are devastating for our patients, okay? If someone is coming in to have surgery, they want to maybe improve their quality of life and go home and get on with life. If they are having a cesarean section, they want to have their C-section, bond with the baby, and recover. But if they get a wound infection, that's going to disrupt everything, okay? And so our work really is all around. We don't want to see any patients, incurring avoidable harm if we can help it, okay? And, these infections are devastating for our patients, but also they're very costly for the healthcare settings. And I think when I've promoted this work over the years, and I've gone to the wards and I said, can you do our surveillance paperwork? And people have said to me they don't have time because they need to check blood pressure. They need to do the vital signs for the patients. And I would say to them, well, actually, if you don't get it right first time for that patient and they develop a wound infection, they are going to be septic. You are going to need IV antibiotics. You're going to need to call the doctor because the patient is very sick, transfer to ITU, and that's all more work for you rather than you just maybe taking 10 seconds to do things right the first time. So very, very important. And what surgical site infection prevention as a group is really all about, let's get it right first time. And so what we know in general, and I don't know, we've got people from infection control here, is that we've had a lot of guidelines for preventing surgical site infections for many years. But what we know is that in a lot of settings, the uptake of these guidelines isn't good enough, okay? So the compliance, when we are wanting people to get it right first time, sometimes it's 30%, for things that we know are evidence can actually make a huge difference for our patients. So our aim really is to try and see whether we can actually work with organizations to improve that. Okay, so we need to change attitudes and perceptions. And if I came to your house, right, you do things in a certain way, and I say to you, I don't think that's right. What are you going to tell me? Who do you think you are? Okay. So yes, the guidelines have been there for many years. We know that the uptake is poor, but if you still go to different organizations today, they may tell you actually there's nothing wrong with what we're doing. And so you need to be pragmatic in how you actually challenge and bring about the change. So there is evidence here from David Lipper and colleagues, where they're looking at the compliance with care bundles. And, that was back in 2015. So what they actually, reported at the time was that the reasons, for the poor compliance was not clear in some of the settings. And they recommended that we needed to be doing more comprehensive surveillance. So does everyone know what surveillance is? Yeah? Good. So we need to do more surveillance, better surveillance. And then when we collect our data, we need to make sure that that data is actually communicated to people who use it to inform and improve clinical practice. Okay? So even for the people who pay for our services, we need to provide them with that data, but also including our patients in everything that we do. So fast forward to 2023. Again, this is in the US, where these authors were examining the barriers to implementing, again, the surgical site infection prevention bundle. So what was the conclusion? It's complicated. If you're going to tell a patient that these things are too complicated, I'm sorry, I can't help it. You're going to get a wound infection anyway. What do you think they're going to say to you? It's okay. We understand these things are complicated. Okay, take that patient away. It's you. You are the patient. Someone is telling you, well, we don't have time. It's complicated. Yeah? So we really need to be challenging, what people are currently doing so we can improve outcomes for as many patients as we can. And someone is saying, it's difficult to implement, or I don't have time. Okay? We need to look at each and every setting where patients have surgery and see what people are doing and think about how we can help them to improve compliance to these bundles. When you look at data from those who've actually taken their time and brought the teams together to address the bundle compliance, you can see that actually, the reductions in avoidable surgical site infections have been significant, more than 50%. Patients were getting infections that could have been avoidable. Yeah? So it's really important, that we find ways of making it work for our organization so no patient will get that avoidable surgical harm after their procedure. So I told you earlier that I worked at Guy's and St. Thomas's for many years. So with teams, at Guy's and St. Thomas's, back then, we did some work within adult cardiac surgery, okay? So what we managed to demonstrate, during those years was actually, it doesn't matter where you start from. If you work together, you can actually prevent any infection, okay? So clean surgery, and, you're getting about 9% in clean surgery. That's scary, isn't it? You've done your equipment right, but actually patients are still getting infections down the line. So that wasn't good. And you can see that, through a series of interventions and us all working together, we managed to reduce those avoidable surgical site infections. And I can tell you that back in 2009, when we started the work and I was going around to the wards or to theaters, I would be told, oh, it was the surgeon. Oh, it was the nurse. who did that. But also some of the things that I was being told is that this patient is high risk anywhere. It doesn't matter what we're going to do, okay? Imagine you go to the hospital and you're told you are high risk, you get a wound infection. There's nothing that we can do about it. Not good enough, okay? So if you know someone is high risk, then mitigate it. And we know that there's many interventions that we can use to mitigate that risk, okay? So again, like I said, you can see that, 2009, very high, rate of surgical site infections. And then by 2016, we were very low. And I went back and I said, do you still have high-risk patients? Yes, we do. What happened? Yeah, so don't ever let anyone tell you that patients are getting infections because they're high risk. We don't want to hear that. We can do something about it. Okay, so it's a lot of work to do, but actually it can be done. And again, another piece of work from Guy's and St. Thomas is, again, for the work that I was leading at the time within cesarean section. One of the highlights from our work here is actually the data collection. So initially, we were using postal questionnaires. We were only getting 5% back. So that wasn't really telling us much, wasn't it? And we thought we were actually okay until we started telephoning patients as part of our validation. Then our rates doubled. At that point, everybody said, we don't want to be here. We have to work harder. And of course, looking at what NICE recommendations are, and then what we were doing, and then we managed to improve, practice. You can see that actually we managed to reduce those rates from about 13.3 to about 5.1. And I know I'm not there anymore, but I'm told, that the rates are still, that low. So you need to have good ways of collecting your data and then utilizing that data, so that you can make a difference for patients. Again, another example from pediatric spinal surgery, okay? And if you check from the cardiac work, the C-section work, I'm sure you can see I've got names on there. We had SSI prevention champions, okay? Which is going to be the pinnacle for the work that we're going to be doing going forward, okay? So if you have a champion in an area who is saying, hey, in this area, okay, in theaters, I want to make sure that the patients are getting antibiotics on time. I want to make sure that the theater environment is clean. I want to make sure that my equipment is clean and that the patient is closed nicely. The junior doctors are supervised, right? That champion is there, to make sure things are being done right, yeah? You can achieve good results. So for pediatric spinal, Mr. Jonathan Lucas, he was the head of service, very senior consultant surgeon. Again, with his leadership, we managed to reduce, rates of, spinal surgery in pediatrics, from, almost 10%, to nothing, zero in 2016, okay? So some people will say, well, actually, when you have surgery, you will get an infection, but actually zero avoidable harm is possible, okay, when people work together. Like I said, it's the champions who were really driving the work in their individual directorates. So very important for us to take forward in that. And so maybe in your organization, you actually don't have any surveillance going, and people are telling you that actually we don't have the funding, for you to be able to collect this data. What we demonstrated at Guy's and St. Thomas's was actually when you do good surveillance, you save a lot of money for the organization, for the NHS, but also improve quality of life for the patients, right? Which is more important. Yes, money is there, but actually we want to be able to make a difference for our patients. So you can see actually our team of 3, was costing us about 90K a year, okay? That's a surveillance team of 3. But actually, in terms of savings, just for one specialty, over $500,000. So if you went to your chief executive and you say to them, give me 90K and I'll save you $500,000, will they say no? So you just need to know how to talk the language and do the calculations locally. And that's why we really are driving on the champion model. Okay, again, even because we had done our work so well over the years, when we wanted, an electronic surgical wound documentation for our patients, I went to the finance director and I was like, I need some money. Oh, Lilian, tell me, how is this going to give Guy's and St. Thomas's money? But, at the end of the conversation, they were more passionate about patient safety than me. It's not just about money, right? And we managed to get money to introduce electronic surgical wound documentation. Okay, like I said, you give me 90K and I'll save you $500,000. It's simple, right? Okay. So that was then at Guys in St. Thomas. So remember, I left Guys in St. Thomas. I talk too much. Let me just check how much time I've got. So now entering a new era, remember what I said about the champion model is one that we are actually taking into the new era because we know that these guidelines have not been implemented enough. So what I started, over a year ago was a campaign to say, let's have an annual SSI Prevention Day, which is similar to the annual Hand Hygiene Day. You all know about the annual Hand Hygiene Day, right? So we want to have an annual SSI Prevention Day so we can raise the profile of surgical site infections. So I said to people, what do you think? And, before I know it, there were loads of people who were interested. Now, as I speak, the whole world is interested in this, and we're actually trying to figure out how we're going to sort ourselves out so we can be able to accommodate, and meet the expectations. So last year, we had a brainstorm meeting with a lot of the top experts within infection control in the UK, Australia, Europe as well. And so we kind of said, how are we going to try and improve, the compliance, with these SSI prevention bundles locally? So we also had interviews with journalists, for this work. And it's been a journey since then. So we've been to many conferences, presented this work, and actually last year I was invited, to go to Australia to present, the work. So we've got a lot of, the Australian, infection control people on board as well. So I went to Portugal and I was in the Netherlands as well. Like I said, the whole world, they want this, and we want you to be part of it. It's all very exciting in the background. We had, very successful education sessions as well, where we were basically having discussions about what's going on, with people, in their local hospitals. So what are we proposing as a new group? Okay, so remember what I said earlier? What I really wanted was an annual SSI Prevention Day, but we thought it's not going to be possible if we don't have people championing it. So now what we're saying is we actually want to identify a champion in every organization, okay, who will be leading on surgical site infection prevention. And then we also want a champion in every country, okay, who kind of have that oversight of what's happening. And then we are going to be developing tools that we'll be using to review practice throughout the year. And so how it's going to work is, you've got that champion, they do their appraisal, throughout the year. Come the annual SSI Prevention Day, they come and tell us what's been happening. Do they need any support? Have they got the leadership support that they need in their organization? But to be honest, going forward, we're actually championing for there to be a permanent resource in every organization who will be looking at surgical site infection prevention, because we know that it works. Like I say, with this champion model, when you are a champion, you can mentor others, you can coach them. They are the subject experts, movers and shakers, on the front line. If you see something that's not right, you challenge it straight away. And of course, like I said, if you don't treat people right, they're not going to do the right thing. So we expect those champions to always be treating people with kindness, compassion, love. In the workplace, very important, and really be promoting those quality improvement initiatives locally. Okay, so who can be an SSI champion? Anyone, okay? I've put some examples there, but anyone can be a champion. Remember, we want champions who span the whole patient's journey. So before the patient even comes in, at pre-assessment, what are you doing for them? Do they need to have a wash? Do they know how to wash? Do they understand the information that you're giving them? Okay, so when they come to the ward, what are you going to do? Do you need to remove the hair? Clippers, we don't want to, to use razor blades. In theaters, who is keeping an eye on things? Afterwards, what's happening to that wound? Is it being kept in situ, or they're dressing in situ for at least, 2 days as recommended by NICE? So these champions are really going to be helping us to make sure that things are being done. Okay, so they must influence at every level. Okay, so we are going to be developing resources that we'll use to train the champions so they know what to do. So they can walk into the chief exec office anytime and say, hello, can I have a conversation? And the chief executive will say, yes, please take a seat. Okay, how many of you have been to the chief exec's office? How many? Good, I can see a hand up. How many of us are scared to go there? Okay, so we will be coaching people. Like I said, at every level, so we make sure that we're covering all the corners. And then, of course, what those champions will do is to actually help us to translate, those guidelines into practice, okay? So you can have that document filed somewhere, but if someone isn't coming to say, hey, by the way, this is how we're supposed to do it here, we don't know whether people are always going to be doing the right things. And to be honest, we are human beings. It depends on the day that we're going to be having. Sometimes we do need someone to come and say, hey, Lilian, what do you think you're doing? Stop it. Okay, and I'll say, oh, I'm sorry. It's one of those days. Yeah? So champions, is going to be critical, with this. Like I said, we're going to be developing resources. So we want to develop a new peer review tool. We are going to be looking at what we already have and then kind of building from there. And of course, our mantra is prevent one surgical site infection, prevent collateral damage. So when you think about that surgical patient, right, they've had surgery, they develop, that wound infection, okay? Maybe it's an abdominal wound infection, right? Maybe the abdomen dehisces, it opens up, and then you've got pus pouring out. What's likely to happen? That patient will probably become septic, and then they end up in ICU. If they go to ICU, what's going to happen? On a ventilator with many lines and a catheter in. So that increases the risk of them getting other infections. Okay, so if you had prevented that, you would have prevented the collateral damage, okay? So we are going to be having so many work streams to try and tackle things from all angles. So no patient will get that avoidable harm after they've had surgery, okay? So when you are implementing it in your own setting, then you are thinking, for example, do we have a sepsis lead desk? We can look at the sepsis side of things and tell us what's happening. The C. diff, what antibiotics are we giving for surgical site infections which are avoidable, and how can we do better, and so forth. So there's a lot there. And remember, we also want the patients and public engagement, so you can work with your PALS team and see what feedback is getting around with infections and use that information to actually improve the education team and everybody. Okay, so when you want them to work, to have a good program, which is what we heard at Guys in St. Thomas, you may want to have an SSI surveillance committee. So all these people here will form that committee and meet regularly and look at the data and look at the compliance and also then identify, things that can be done better for our patients. Okay, so it's all about challenging the status quo. Like I said, if I came to your house and I said, can you change the way you've been doing things? You'll probably say, no. But we want to challenge the status quo, and we want people to be brave to challenge, because it could be you in that next bed, tomorrow, okay? So again, probably the color isn't as clear here, but, how do you influence your finance manager to give you the money? I've already told you how, right? And so, if you're all busy, we don't have time to do surveillance, but hey, if that patient gets a wound infection, you're going to be busier, right? So it's about thinking, of the, language that you can use to convince people to come on board as well. And we're all frustrated. We're tired. The pandemic has worn us all. So how do you get people to become motivated to prevent harm for patients, okay? So why are we in healthcare? To make a difference for patients. Very important. And of course, like I said, we want to look at the whole patient's journey and make sure that we're making a difference for all our patients. Engage your senior leadership. Okay, this is an example for midwifery. So if you're doing cesarean section, you want your director of midwifery, you want your consultant, obstetrician, and you want all the other people involved. So you can all be looking at things from a holistic perspective. And of course, how do you overcome any barriers that you may encounter? Like I said, at the beginning, we've got that acronym reuse, strategy. So you want to reduce surgical site infection burden, which is your ultimate goal, but actually you need surveillance methods which will help you to establish where you are at any time. And then use that data to inform and improve, not just collecting it. When you've improved, sustain the changes, okay? And make sure you've got established governance structures where SSI prevention interventions are within, those existing governance structures, but having that SSI prevention champion model. Very, very important. A lot of these things, all you need is a champion. And I've been given the red light that I need to stop now. Okay, so, people may experience, a lot of the negativity in the beginning. But of course, what we need to be able to always focus on is the patient in, making shared decision a reality. Nothing about me without me. Develop things together. Work together, use those good, data collection methods together. And when it comes to the SSI Prevention Day, share what's gone well, share the challenges, and let's work together, to prevent those avoidable surgical site infections. So, hey, at SSI Prevention, we say adopt a resilient, patient-focused, multidisciplinary collaborative approach is very, very important, okay? And remember, no patient wants to be the 1%. So I don't want to hear we are below the national average, not good enough. No, we don't want any if we can help it. Thank you very much for listening. So, like I said, we're going to be developing the resources to support this work as well. And you're all very welcome to join us. We are a lovely bunch, global group. So you can help us, develop some of the materials that we're going to be using. Okay, thank you very much.